Hello everyone, welcome back to my channel. So the topic for today is placenta previa. So what is placenta previa? Placenta previa is actually a part of antepartum hemorrhages. What is this antepartum hemorrhage? So it is the bleeding from the genital tract after 28 weeks of pregnancy but before birth of the baby. So what is it? It is just bleeding from the genital tract after 28 weeks. So then we move on to placenta previa. So this placenta previa when the placenta, suppose this is the uterus, this is the lower segment, okay, this from here is the lower segment, this is the baby, okay. If the placenta is implanted somewhere at this portion, it is called as placenta previa. So when the placenta is implanted partially or completely over the lower uterine segment, it is called as placenta previa. Then we discuss about the risk factors or the high risk factors for placenta previa. So there is multiparity. This is one of the most common factor which influences the placenta previa formation. Then the maternal age more than 35 increases fourfold increase in the risk of placenta previa. The maternal age more than 35 is an important factor of placenta previa and the risk increases fourfold. Then infertility treatment, previous cesarean scar, then multiple pregnancies, smoking causes placental hypertrophy to composite carbon monoxide induced hypoxemia. So smoking is also a risk factor, okay. So then we move on to the etiology of placenta previa. So there are four theories that explain the development of placenta previa. So what are these four theories? The first theory is the dropping down theory. In this, the fertilized ovum gets implanted into the lower segment, of the uterus. Poor decidual reaction in the upper segment may be the cause. Okay, then this explains the formation of central placenta previa. Then the next theory is persistence of chorionic cavity in the decidua capsularis and its subsequent development into the capsular placenta and it comes in contact with the decidua vera and leads to formation of placenta previa. Then the next theory is defective decidua results in spreading of the chorionic villi in the area in the uterine wall to get the nourishment, okay, and then it becomes adhered in the lower segment of the uterus, so it forms as a low-lying placenta. Then there is this fourth theory which says big surface area of the placenta. So big surface area, this is in case of twins, okay, where the placenta is very large and encroaches into the lower uterine segment. Then we discuss about the risk factors or the high risk factors for placenta previa. So there is multiparity. This is one of the most common factor which influences the placenta previa formation. Then the maternal age more than 35 increases fourfold increase in the risk of placenta previa. The maternal age more than 35 is an important factor of placenta previa and the risk increases fourfold. Then infertility treatment, previous cesarean scar, then multiple pregnancies, smoking causes placental hypertrophy to composite carbon monoxide induced hypoxemia. So smoking is also a risk factor. So this is the placenta. This is a normal placenta. Then we have the type 1 low-lying placenta. The major part of the placenta is attached to the upper segment and only the lower margin encroaches onto the lower segment but not up to the internal os. So, low-lying placenta leading edge is within 2 to 3.5 from the internal cervical os. Then we have C, the marginal placenta. The placenta reaches the margin of the internal os but it never covers it. It is less than 2 centimeter from the internal os. Then we have another, that is complete placenta previa. The placenta completely covers the internal os. This is actually type 4. There is another type 3 in which, suppose this is the placenta covers the internal os partially, partially but does not entirely do so when fully dilated. So this is fully dilated, the placenta moves a bit towards the upper side and it does not fully cover the internal os. So that is type 3, incomplete or partial placenta previa. Whereas in this case, what happens is even when fully dilated, it completely covers the os. So these were the types and degrees of placenta previa. So the type 3 constitutes about 1/3 of the cases. Type 3 is 1/3. So in this case, the placenta is more likely to be compressed. If vaginal delivery is allowed, more chance of cord compression or cord prolapse. The last two may produce fetal anoxia or even death. So fetal complications, fetal anoxia or fetal death. So these were the types or the degrees of type of. There is also another type called as the dangerous placenta previa. So it is type 2 posterior placenta previa. So this is the sacrum, and this is the uterus, this is the placenta. Then what happens is, because of the curved birth canal, major thickness of the placenta about 2.5 centimeter overlies the sacral promontory, thereby diminishing the anteroposterior diameter of the inlet and prevents engagement of the presenting part and this also hinders the effective compression of the separated placenta. So now we start with the causes of this bleeding. As the placenta eventually grows in the later months of the pregnancy and the lower segment progressively dilates, the inelastic placenta is sheared off the wall of the lower segment. This leads to opening up of the uteroplacental vessels in the lower segment, and this leads to one episode of bleeding. As it is physiological phenomenon which leads to the separation of the placenta, the bleeding is said to be inevitable. Inevitable bleeding. Okay. However, the separation of the placenta can also be evoked by trauma caused when there is vaginal examine or coital act, and external version or during high rupture of the membranes. The blood is almost always maternal. Although fetal blood may escape from the tone villi when the placenta is separated during trauma. There is also another type called as the dangerous placenta previa. So it is type 2 posterior placenta previa. So this is the sacrum, and this is the uterus, this is the placenta. Then what happens is, because of the curved birth canal, major thickness of the placenta about 2.5 centimeter overlies the sacral promontory, thereby diminishing the anteroposterior diameter of the inlet and prevents engagement of the presenting part and prevents and this also hinders the effective compression of the separated placenta. So now we start with the causes of this bleeding. As the placenta eventually grows in the later months of the pregnancy and the lower segment progressively dilates, the inelastic placenta is sheared off the wall of the lower segment. This leads to opening up of the uteroplacental vessels in the lower segment, and this leads to one episode of bleeding. As it is physiological phenomenon which leads to the separation of the placenta, the bleeding is said to be inevitable. Inevitable bleeding. Okay. However, the separation of the placenta can also be evoked by trauma caused when there is vaginal examine or coital act, and external version or during high rupture of the membranes. The blood is almost always maternal. Although fetal blood may escape from the tone villi when the placenta is separated during trauma. So, the signs of placenta previa are there is visible blood loss, and general condition and anemia are all proportionate to the visible blood loss. The size of the uterus is corresponding to the period of gestation. The uterus is relaxed, soft, and elastic, and there is persistence of malpresentation. Usually a breech presentation is seen. In these cases, the head is floating. FHS is present unless there is major separation of placenta. And slowing of the fetal heart rate, decrease in FHS, slowing of the fetal heart rate by pressing the head down. Suppose this is the uterus, this is the head of the baby. When we push the head down into the pelvis, there is slowing of the fetal heart rate, and it soon recovers as the pressure is released. Recovery of this is called as Stalworthy sign. Then on inspection, we find that there is a lot of bleeding. The bleeding is bright red. This differentiates it from abruptio placentae. On abruptio placentae, which is a differential diagnosis for it. So in an MCQ, if you see that a patient comes with PV bleeding and if it is bright red given in the question, so you will mark placenta previa and not abruptio placentae. But there also will be many differentiating features which would be given in the question. Let's see. So placenta previa, the only symptom of placenta previa is vaginal bleeding. It is sudden, painless, causeless, and recurrent bleeding. It especially occurs during sleep, and the patient is frightened because she sees herself in a pool of blood. Usually, the causes of trauma and hypertension are absent here, but preeclampsia usually worsens or complicates the case of placenta previa. The majority of cases, bleeding occurs before 38 weeks. Okay, so for the diagnosis of placenta previa, there is painless and recurrent vaginal bleeding, and for the diagnosis again we need sonography. So in sonography we have the ultrasonography, the TVS, TAS, the TPS and MRI. Then in sonography, it provides the simplest and the most precise and safest method for placental localization in transabdominal. The accuracy after 30th week is almost 100%. In TVS, it is more accurate, even more than TAS, and it's safe and obviates the discomfort of full bladder and is most accurate, almost 100%. And then there is also one more called as the TPS. There is also color Doppler and MRI, which does not have a risk of radiation. No risk of radiation. Next week. Okay, so for the diagnosis of placenta previa, there is painless and recurrent vaginal bleeding, and for the diagnosis again we need sonography. So in sonography we have the and fatal complications. So in maternal complications, it could be, first is the breech presentation. This is a malposition, and placenta previa could be found with breech presentation. It could also be there with a transverse lie. Premature labor, early rupture of membranes. Then there is slow dilation of cervix. Then there is intrapartum hemorrhage. And there is increased incidence of operative interference. That is, there could be a need of LSCS need. Okay, then postpartum hemorrhage in this is due to, there could also be one maternal complication which is PPH. In this PPH, it is due to imperfect retraction of the placenta. It could also be due to large surface area and placenta previa accreta. Placenta previa accreta is a serious complication of placenta previa. What is placenta accreta? It is when the placenta gets adhered into the myometrium, trauma to the cervix and the lower segment, trauma, and death due to massive hemorrhage. Then we also have fetal complications, that is low birth weight babies can be seen. Fetal growth restriction, asphyxia, intrauterine death, and birth injuries are common during operative interference. Then congenital malformations, can also be present, and during puerperium there can be sepsis, subinvolution, and embolism. Then we have the prognosis. The prognosis can be as follows. First, there has to be early diagnosis. Then there is no PVs. No PV. Why no PV? Because it will lead to increased placental separation, and the bleeding increases. Then free availability of blood transfusion. Then potent antibiotics have to be given, and more usage of cesarean section is done during placenta previa for a safer delivery. Then we have the management of placenta previa. In the management of placenta previa, first we have to see the prevention. Suppose there is placenta previa and we want to prevent it. What are the measures that we can take? Then management, regular antenatal care. Antenatal diagnosis is scan at 34 weeks, confirms the diagnosis, and proper measures can be taken if it has to be a vaginal or a cesarean delivery. Then significance of warning hemorrhage needs to be detected Then at home, the patient has to be put to bed. A gentle abdominal examination has to be done to see the height of the uterus, to see fetal heart rate should be heard in the first place, and any tenderness should be noted of the uterus. Then the patient should be immediately transferred to the hospital and admitted. Then the treatment on admission. There are two treatments. There is an immediate treatment, and there is a formulation line of treatment. Okay. In the formulation line of treatment, there are two parts that we have here. In these two parts, there is expectant, that is what all things can go wrong and how can we avoid it, and then there is active or definite management. Then for immediate management, we can see the amount of blood loss. So blood transfusion can be there. Blood transfusion has to be kept ready. There is anemia, so there is pallor, pulse rate and blood pressure, pulse, BP, etc. Okay. Then blood samples are taken, CBC. Okay, CBC sample is taken. Then IV cannulation. Then gentle vulval examination to see for any kind of bleeding. Then expectant management. Expectant management has two parts. There is a criteria called as the McAfee. There is another criteria for expectant management, that is McAfee and Johnson's criteria. So in this criteria, there are vital prerequisites. So what are the prerequisites here? The availability for blood transfusion. Then the second criteria, it should be that facilities of LSCS should be available for 24 hours after the patient has been admitted and is stable. Then selection of the cases for expectant management. So the cases which are to be selected should have a hemoglobin of more than 10, and hematocrit should be 30% or more than that. Then duration of pregnancy should be less than 37 weeks, and active bleeding should be absent. No active bleeding. Then conduct of the expectant treatment, that is the patient should be given bed rest, investigation should be done, inspection should be done periodically, and a gentle examination with cuscos should be done to see for any kind of cervical or vaginal lesions. However, there can be a preterm delivery where there is risk of hemorrhage. If there is risk of hemorrhage, then the baby might be delivered early, then the fetus, if dead, and in congenital malformation. Then a steroid therapy has to be given for patients if the fetus is less than 34 weeks. Betamethasone is usually given as it decreases respiratory distress in newborn. So we have seen the expectant management now. So, active management of placenta previa. In active management of placenta previa, it should only be done if the fetus is more than 37 weeks and in labor or the patient is bleeding. Then in active management, a lower segment cesarean section is usually done if the placenta is more than 2 to 3 centimeter from the internal os. Then all PPH patients are to be admitted and general and abdominal examination has to be done. Basic investigations have to be sent and localize of the placenta should be done using USG. So there are two managements here. There is an expectant management as we saw, and then there is an active interference. In expectant management, we have to see that there is no active bleeding. The patient is less than 37 weeks and the patient is stable hemodynamically with the FHS of the fetus being normal. Then in active interference, there the bleeding continues. Pregnancy is more than 37 weeks. Patient is in labor and FHS is non-reassuring. Steroid therapy has to be given here if the duration of the pregnancy is less than 34 weeks. Then ultrasonographic evidence reveals placenta more than 2 to 3 centimeter in low-lying cesarean delivery. Then when trial of labor is to be decided or is to be given, we do ARM with oxytocin infusion has to be given, and satisfactory progress vaginal delivery, bleeding continues, no labor, that has to be given cesarean. Then placental edge within 2 centimeter, no examination, directly pose the patient for cesarean section. So this was all about placenta previa. Let's revise everything once. So what is placenta previa? It is a part of antepartum hemorrhages, bleeding through the genital tract after 28 weeks, and it usually occurs at the lower uterine segment, that is the placenta previa. Then there are four theories, that is the dropping down theory, then persistence of chorionic cavity, big surface area, then placenta previa. The risk factors are multiparity, multiple pregnancy, smoking, LSCS, and infertility. Then the types are normal, low lying, leading edge of the placenta is within 2 to 3.5 centimeter. Then there is one type 3 also, which is incomplete or partial. Even when fully dilated, it does not completely cover the internal os. But whereas in type 4, it completely covers the internal os, even when dilated. Then there is a dangerous type, which is the type 2 posterior. It causes fetal anoxia or even death of the fetus. Then placenta previa, signs and symptoms, which is vaginal bleeding, sudden, painless, causeless, and recurrent bleeding. Then sleep. The patient wakes up frightened as she finds herself in the pool of blood. Preeclampsia aggravates placenta previa symptoms. And signs of placenta previa. Uterus corresponds to the period of gestation. It is relaxed, soft, and elastic. It shows breech presentation. The head is floating, and FHS is present, but it is decreased and on pressure and it is increased on releasing the pressure. This is called as Stalworthy sign. The bleeding is bright red on inspection, which is placenta previa. The on antepartum hemorrhages also have abruptio placentae, which does not have this bright red blood, which differentiates it from placenta previa. So diagnosis, painless and recurrent vaginal bleeding. Placentography usually done by USG. Then complications, breech or transverse lie, postpartum hemorrhage, intrapartum hemorrhage, early rupture of membranes, then fetal, LBW, FGR, asphyxia, intrauterine death, congenital malformations. Then the prognosis is best if done early, no PV examination, as it increases the placental separation and increased risk of bleeding. Then management, antenatal care has to be done, patient is put to bed, gentle abdominal examination has to be done, and then transfer to the hospital and has to be admitted. Then immediate and formulation of blood transfusion, then CBC sample, IV cannula, gentle vulval examination, expectant and definitive management. McAfee and Johnson's criteria, blood transfusion, LSCS, should be kept ready for at least 24 hours. Then cases, that is hemoglobin should be more than 10% and hematocrit more than 30%. And the patient should be less than 37 weeks and no active bleeding. Bed rest, inspection, Cusco's examination should be done for any vaginal or cervical lesions. Steroid, live less than 34 weeks. Betamethasone, decrease in respiratory distress in newborn. And as we saw, active management and then expectant management. So thank you very much.